Welcome back Term 3. It is great to see you again. Thank you for joining me today. Today, we will be discussing respiratory distress syndrome in the neonate population. Per the American Thoracic Society, respiratory distress syndrome is the leading cause of death in premature infants. In addition to being the fifth leading cause of death for infants under 1 year of age. So, it's important to discuss this disease, so you can have a clear understanding, as respiratory therapists. Respiratory distress syndrome is also known as the hyaline membrane disease, RDS, or pulmonary immaturity. RDS is primarily caused by a surfactant deficiency. While the fetus is developing in the womb, surfactant is being produced. However, fetal lungs only fully develop between 34 and 37 weeks. Therefore, the incidence and severity of respiratory distress syndrome is related inversely to the gestational age of the newborn infant. Due to the deficiency of surfactant in the lungs of a neonate, the lack of surfactant causes a generalized alveolar collapse that leads to respiratory failure. Surfactant lowers the surface tension of the liquid that coats the lungs, allowing the alveoli to remain open and oxygenate. When there is a lack of surfactant, the alveoli collapse with each breath, which leads to a severe impairment in oxygenation and expelling of carbon dioxide. If the situation is not corrected, the end result is respiratory failure from RDS. Let's now discuss complications that can arise from RDS. The lack of surfactant and the pressure caused by the neonate's work of breathing, or due to mechanical ventilation, can potentially cause the alveoli to rupture. In addition, air leaking into the mediastinum, the sac surrounding the heart, or into the alveoli and becoming trapped, can also be a result of RDS. A pneumothorax can also develop, causing air to escape into the chest wall. With a surfactant deficiency, the lungs become diffusely electatic, triggering inflammation and pulmonary edema. Additional complications you may see resulting from RDS are bronchopulmonary dysplasia, reactive airway disease, intraventricular hemorrhage, retinopathy of prematurity, and necrotizing enterocolitis. Let's change it up and move to our state-of-the-art lab. Although the lack of surfactant is the primary cause of RDS in premature infants, other risk factors that increase the probability of an infant developing RDS, other than prematurity, include the following: diabetes in a mother, cesarean delivery, cold stress, rapid labor, siblings whom developed RDS, delivery complications that reduce blood flow to the baby, abnormal placental conditions, and umbilical cord disorders. Let's now discuss clinical manifestations of RDS. Symptoms of neonatal RDS can start as early as minutes after birth, but usually present within the first several hours of life. The symptoms that can be observed in an infant suffering from respiratory distress syndrome are bluish color of the skin and mucous membranes, grunting, nasal flaring, rapid breathing, shallow breathing, shortness of breath, periods of apnea, retractions that can have seesaw appearance, or decreased urine output. Additionally, because of impaired surfactant synthesis, secretion leading to atelectasis, ventilation perfusion, hypoventilation, resultant hypoxemia and hypercarbia, ABGs, will reflect respiratory and metabolic acidosis that causes pulmonary vasoconstriction, resulting in impaired endothelial and epithelial integrity, with leakage of protein exudates and formation of hyaline membranes. I know this is heavy stuff, but please stay with me. Let's now discuss X-rays and RDS. Chest X-rays will usually reveal poor lung expansion, and air bronchograms are observed together with a ground glass appearance in the lung fields. While viewing the chest radiograph for RDS, the severity can usually be categorized into 4 categories. Stage 1 will reflect a fine, diffuse reticulogranular pattern over the lung fields. Stage 2 will have air bronchograms around the heart border, and the lung will appear denser. Stage 3 will be a more acute version of Stage 2. The lung will appear denser than the previous stage and the air bronchograms will have advanced beyond the heart border. Stage 4 is complete washout. So, let's now talk about the hands-on aspect of a respiratory therapist handling RDS. But first, I think we need a change of scenery. How about we mosey along to the NICU? This is a room in the NICU where a neonate would be admitted, but as you can see at this time, it is empty. So, let's continue our lecture in here. One of the greatest breakthroughs in the fight against RDS was the development of surfactant replacement therapy, which saves premature infants from an almost certain death. Its use has led to a dramatic decrease in mortality from nearly 100% to less than 10%. Typically, infants are able to breathe more easily within a few hours of receiving surfactant, and complications, such as lung rupture, are less likely to occur. The first dose of surfactant needs to be given as soon as a diagnosis of RDS is made. As you can see in this picture, administration of surfactant is directly into the baby's lungs via the endotracheal tube. Ideally, the dose should be given within 1 hour of birth, or before 2 hours of age. A repeat dose should be given within 4 to 12 hours, if the patient is still intubated and requiring more than 30 to 40% oxygen. A blood gas should then be performed within 15 to 20 minutes of the dose. A chest radiograph should be checked both 1 hour and 4 to 6 hours after the initial dose to avoid hyperinflation. The clinical response can be unpredictable after the surfactant administration, but lung compliance usually improves, sometimes quite rapidly. ABGs should be monitored frequently, and the ventilator should be adjusted to keep the PaCO2 above 40 mm of mercury. Occasionally, gas exchange deteriorates after surfactant administration, requiring a temporary increase in settings to facilitate spreading or suctioning if the ET tube is becoming obstructed. In either case, close surveillance of the chest wall movement and frequent monitoring of blood gases should be maintained, especially during the first 3 hours after dosing. This will minimize the complications of either volume trauma or atelectasis. In addition to surfactant administration, the neonate should be placed on mechanical ventilation in order to maintain the airway and prevent the alveoli from collapsing and managing atelectasis of the lungs. A neonate will be mechanically ventilated if they meet the indication of an oxygen need greater than 80%, with a CPAP of 8 centimeters of water. If there is increasing hypercarbia with respiratory acidosis, or if apneic episodes are prolonged. The goals of ventilatory management in the intubated infant are to maintain adequate oxygenation and ventilation while minimizing ventilator-induced lung injury. To achieve this, utilize a strategy of permissive hypercapnia, maintaining PaCO2 between 45 to 55 mm of mercury, reducing volume trauma, and preventing harmful effects of hypocarbia. To reduce further the risk of volume trauma, adjust ventilatory pressures to maintain tidal volumes between 4 to 5 milliliters per kilogram. In addition to mechanical ventilation, non-invasive continuous positive airway pressure can also be administered through the nares via nasal prongs, providing continuous oxygen that is pressurized, which will allow the airways to remain open and oxygenate. When placing an infant on CPAP, the goal is to stabilize the alveoli and allow surfactant production to take place and prevention of mechanical ventilation. CPAP is administered between 4 and 6 centimeters of water. Lower pressures do not maintain lung inflation, and higher pressures often cause gastric distension. The limitations to the use of nasal CPAP include hypercarbia, frequent episodes of apnea, gastric distension and breakdown of nasal skin and mucosa from the mask prongs. Another therapy that can be utilized with RDS is the extracorporeal membrane oxygenation, which is also called ECMO. ECMO places oxygen directly into the blood, if mechanical ventilation is not an option, to improve oxygenation levels. Okay, now that we have covered the heavy stuff, let's head back to the classroom so we can wrap this lecture up. So, lastly but not least, I am going to lecture about the RT's role. The respiratory therapist plays a monumental role in the care of premature infants with respiratory distress syndrome. Due to the scope of an RT, it allows and requires the respiratory therapist to be involved in almost every facet of managing a premature infant with RDS. With that said, always remember that the primary focus of the RT at all times is to maintain the airway, support oxygenation, and ventilation. You made it through another one of my lectures. It was great seeing you again, Term 3. Thank you for your attention.